ACLF is very severe conditions in patients with liver cirrhosis. It is characterized by organ failure after an acute decompensating event. There are several precipitants which can precipitate ACLF, especially bacterial infections, alcoholic hepatitis, and bleeding are the ones who account for almost 98% of all precipitants that can be identified. Nevertheless, there are also 30% of the patients who decompensate and develop ACLF without a precipitating event that can be identified. We think that this is bacterial translocation ongoing in these patients, which lead them to the organ failures. Bacterial translocation, as I said, probably accounts for many patients who develop ACLF without precipitating events, but also in patients who develop infections, especially spontaneous bacterial peritonitis. We think that bacterial translocation is very important. And of course, bacterial translocation or microbial translocation from the gut is very tightly linked to the microbiome. So studying the microbiome, we may gain more insight into the development of decompensation and also acute-on-chronic liver failure. Indeed, we think that the bacteria and their components and also the microbes and their components, when translocating into the systemic or portal circulation, blood circulation, they interact with immune cells and they fuel the systemic inflammation, which rises very high. We have many markers that show that they are altered in patients with acute-on-chronic liver failure. And especially this systemic inflammation is the one who leads to the organ failure, on our opinion, and leading to dysfunction of the parenchymal role of the organs in different organs. The precipitating events are very important because they lead to the organ failure. So if we treat the precipitating event, for example, if we treat with adequate antibiotic regimes, we could show in the PREDICT study that you can decrease the development of ACLF in our patients. So I think treatment of precipitants before they get to the ACLF, it's extremely important in these patients. Nevertheless, once we have ACLF, we are very limited. There are no treatments who are really assigned for ACLF that can help us, except for liver transplantation. And liver transplantation can be used only in very small number of patients with ACLF. So it's not really an option for all the other patients. So this is an unmet need. On the one side, the diagnosis or identification of patients with pre-ACLF, and the other is the treatment of patients with ACLF. So treating the precipitants may help, but it's not enough to prevent ACLF. And once ACLF is present, what we need is organ support, and there are no good data about what is the organ support, exact organ support that we need to do it. So there is a huge unmet need in a patient's population which is very vulnerable with a very high mortality. ACLF is relatively easy to identify because you see the organ failure and then you know that this is the patient who has ACLF. Nevertheless, at that moment, we are limited therapies. For this reason, it is important to predict the patients coming in the hospital with an acute decompensation. And these are the so-called pre-ACLF patients. We are working very hard in identifying markers and also tools to predict the patients who develop ACLF, so to identify the pre-ACLF patient. Nevertheless, we need more research on that and we need better markers. Since when the ACLF is once present, then we have an ongoing organ failure, which is very difficult to reverse that. This is what we have discussed in the community for a long time. When do we reach the point of no return? When is the care futile? And indeed in ACLF, we have the problem that, of course, if the condition gallops and goes very fast, then we might not be able to halt it. Nevertheless, we need also strategies for the patients how to bridge them to liver transplant. Because we have shown convincingly all over the world, there are good data showing that liver transplant helps the patients to stay alive and rescue the patients. Nevertheless, we think that we have to go at early stages of ACLF and even before that in patients with very high systemic inflammation at admission, the so-called pre-ACLF patients, to identify them and to treat them. So this may be really the key of success, preventing organ failure, preventing further organ failure, or bridging to liver transplant. I think we are lost without them, so we need them. The multidisciplinary approach is the key to success also in ACLF. Especially these patients, not only the structures, so ER, normal ward and ICU, but also the specific specialties are involved in this. We need the surgeons, we need the intensivists, we need the nephrologists, because as you know, kidney failure is the most prevalent organ failure in ACLF. We need the cardiologist, circulatory failure, and also to explore and understand what are the mechanisms leading to this organ, to the failing of these organs in presence of liver cirrhosis and in presence of acute decompensation of liver cirrhosis. So this is, I think, a conditio sine qua non that can lead to success in our patients. We have different organ systems which are affected by ACLF. Therefore, what we need is, on the one side, diverse and adapted, personalized organ support. What we need is disease modifiers, which can reverse the precipitating event and the progressing liver disease. And what we need is also bridging therapies in order to bridge to liver transplant. Patients with ACLF, they have many contraindications for liver transplantation. For example, an overt bacterial infection, fungal infection. They may have respiratory problems which preclude them to be listed in some patients for liver transplantation. For this reason, we need many multimodal strategies and we need combination of strategies in order to improve this care in these patients. I think there is a lot of industry interest. Nevertheless, this is very challenging since the high mortality, the vulnerable patients population. Nevertheless, there has been an increasing interest of several companies which have particular interest in ACLF. And we are very grateful to these companies that are trying to help us to fight against this very dramatic disease. I think it's very important that the design of the clinical trials, we account for heterogeneity. Nevertheless, once the organs are failing, then there is not a big difference between the different etiologies. There are specific things, as I said before, the precipitating events, that you can treat them or address them, alcoholic hepatitis, for example, with prednisolone and so on. Nevertheless, these are really very little and limited. So for the clinical trials, the most important thing are the hard endpoints and also having the option to bridge to liver transplant the patient. So a bridging option is, I think, in ACLF therapy, it's an extremely important endpoint. And for this reason, we need strategies and we need treatments that can help us to deal with our patients, especially in this critical, very critical phase. So I think what is very important is the identification of the patients on the one side, in the ER, in the ICU, and in the ward. So you need a very good infrastructure to identify patients across these three sites in each department. And I think this is the challenge because many departments do not have access to ICU or do not have access to ER. And on the other side, what is also very important is the network of referring hospitals, especially to academic centers. So having in place referral coordination, having in place access to ER, normal ward, and the ICU is the key to success for recruiting for clinical trials in this particular condition, ACLF, which is, to be honest, very time sensitive and also challenging. I think what is very important is the systemic inflammation, to address systemic inflammation. The drivers of systemic inflammation, how it evolves, and the consequences of systemic inflammation, what we see in the patients with the failing organs. So all strategies that can decrease systemic inflammation or modulate systemic inflammation in terms of a beneficial effect are most welcome and will be successful. For example, If we take out metabolites, which are a very clear sign or are part of the signature of patients with acute-on-chronic liver failure in different categories and different pathways, for example, metabolism of immune cells. If we take out these metabolites and we let the immune cells to recover and to have a good and to decrease the immune paralysis that we have and to improve their outcome in terms of fighting against the bacteria, fighting against infection, but not fighting against the organs, because this is the overriding systemic inflammation which leads to organ failure. This would be, I think, a great advance. And there are several strategies which are very promising, in my opinion, and should be further followed in this regard. I think we have done a lot of progress in the last months or in last year in terms of aligning with different associations across the world, with APASL and with ASLD. And I think what we need is, of course, patients-adopted definitions and patients-adopted therapies, either for each patient's category. There are also differences between the continents because the etiology of liver disease is different and also the precipitants leading the patients to ACLF are different. For example, hepatitis B is more prevalent in Asia, while alcohol and bacterial infection are more prevalent in the Western countries. So, of course, we should have some site-specific definitions and also treatment strategies. Nevertheless, the overall ideas of the organs of the liver failure and acute-on-chronic liver failure should be harmonized, and we are in the best way to go there. So I am very, very positive about this collaboration we have across the continents.